Hey team, welcome to another video. Albie and I teamed up on this one, so I hope you enjoy it. We talked about borderline personality disorder and whether some people are untreatable and ways to address treatment-resistant issues there. We spoke a bit about a mother who had postpartum anxiety and how that may have affected her toddler and the kind of guilt that carried on from there. We also spoke about hypnopompic and hypnagogic hallucinations, and also we spoke about ADHD, anxiety, depression, and the importance of considering physical health in mental health assessments. If that sounds like your cup of tea, let's get into it. Okie dokie, quick sip of tea. Before we get started, this is chamomile. Actually, one of the previous comments was what's my favorite kinds of teas. I have multiple teas over the day at different points of time. So in the morning, it's like lemon and ginger. And then like maybe 2-3 p.m. it's peppermint. And then my wind down tea is chamomile. So good. When I drink my chamomile, it's time to relax. So we're just chilling here. We're just gonna relax. But for me, yeah, it's 7 p.m., which is like my wind down time. But I didn't have time to do this video earlier, so yeah, I'm gonna just take it easy with this video. No pressure. Anyway, the first comment is from Official Galactic Princess. Love the name. I'm so interested if you could describe treatment considerations for comorbid conditions, in brackets, medical conditions that are simultaneously present in a patient. And I have depression and generalized anxiety disorder. And after a while of dealing with that and feeling stuck for roughly a year, I discovered ADHD, ? And it made sense. After reflecting on my whole life, it fits in a lot of ways, even if it isn't 100% certain. So I know that comment is not 100% clear, and that's all good. But I liked this comment because it highlights two important points that aren't well known. And the first part is really around medical conditions and mental illness. But the second is ADHD and people who have depression and anxiety. So, sorry, another sip of tea and then let's go. Okay, so physical health considerations in psychiatry, absolutely critical. And in fact, it's the first set of differentials that must be excluded in all presentations. So if someone comes with even like a presentation of psychosis, like if someone has a psychosis, typically people will go, that's a psychiatric situation. Wrong. You don't know that. It could be a delirium. It could be an encephalitis. It could be, a thyrotoxic storm. It could be so many physical health things. And if you give someone with, an encephalitis, an antipsychotic, you're not treating the cause. You're not getting to the core of the issue because there's still either infective or autoimmune process happening that you need to treat. And so you risk making things worse. So really important in psychiatry to always consider the physical health side of things. Now that's quite extreme examples, but when we come down to everyday examples, like how often do you see depression without comorbid physical health issues, right? Rarely. There's often like heart disease, strokes, diabetes, metabolic syndrome, obesity. All these things are strongly interrelated and increase the risk of mental health issues, and mental health issues increase the risk of physical health issues. So you can't just be a mental health practitioner, you have to be holistic. And that's why I say, complex problems need complex solutions. It's about multimodal therapy. So, as important as the mental health medications is, there's other aspects to the plan such as health, diet, exercise, and in exercise doing, strength work, cardio, anaerobic work, mobility work. And my gosh, sleep. Like I'm actually not being a good ambassador of sleep because usually 7 p.m. is when I start to wind down, and I've just started this YouTube video. So, busted. But then there's another element, and that is being good enough. So I don't need 100% perfection in my routines. I just need to be good enough, and I get to sleep in tomorrow morning. So I'm allowing myself to do technology for a little bit later. But I just wanted to make that important point. And anxiety and physical health conditions also incredibly common, and it can be a core part of the anxiety, especially in like illness anxiety disorder. health anxiety. So where people are Googling, so people are hypersensitive to their normal sensations that other people would ignore or not even notice. And then they kind of catastrophize what those sensations might be, and might be preoccupied with the idea that it could be some serious adverse health thing. So, getting like a kind of slight palpitation and then thinking you're having a heart attack, and then that triggering a panic attack. So it can be absolutely in the core of anxiety. And I think physical, like your brain and your body are just so intimately interrelated. Like your organs are functioning based on what neurons in your brain are like they release chemical messengers to influence what your organs do. Even things as simple as your heart rate. When I hear about someone who's got positional orthostatic tachycardia syndrome, which is very common, it's when someone stands up and then their heart rate goes really, really quick. And some people are aware of it, some people aren't. It's not diagnostic, but that gets me thinking, like, is there a autonomic nervous system issue here, and where did that come from? Obviously there is. And where do we learn how to regulate our autonomic nervous system? Through cuddles with our parents, basically, through being safe and caressed in our parents' hands, and that kind of thing. So it's not diagnostic. I'm not saying people with POTS have problems with their caregivers by definition, but it makes me want to ask those questions to explore it. Okay, so it's not about being certain and diagnostic. It's just about being curious and making links. Autoimmune diseases, my gosh, rheumatoid arthritis, like inflammatory bowel disease. You look at people who have high levels of stress in their life, or significant anxiety, depression histories, trauma even, and their immune systems do have higher rates of autoimmune issues. And it's almost like how the mind attacks itself, the body starts to attack itself in some people. Obviously not everyone, right? I don't want to be generalistic in how this is sounding, but it's just about stimulating the curiosity when you're doing the review. Okay, so that's part one of the question. Part two of the question was the fact that official Galactic Princess has had depression and generalized anxiety for a while, and then has discovered ADHD. So, depression to once, okay. People with ADHD are at increased risks of depression and anxiety, and people with depression and anxiety could have misdiagnosed ADHD. Both of those situations are possible. If you've had ADHD that's undiagnosed, and you've had executive dysfunction in classrooms or at work, and you're performing poorly because of issues in your ability to attend and complete work, and you're getting bad feedback even though you're trying your hardest, that's going to affect your mood and self-esteem. That's going to increase the risk of depression. But interestingly, anxiety as well is that's in anxiety. You can have ruminations, you can have poor sleep, you can have distractibility, and you can zone out if you're in an anxious state with catastrophization. All those things can exist in ADHD as well, right? And it's challenging to disentangle whether it's an anxiety or an ADHD symptom. In anxiety, it's usually anxious ruminations, whereas in ADHD, it's usually kind of distractible thoughts. So not necessarily with an anxious component. The poor sleep in anxiety is usually because of anxious ruminations, catastrophization, worrying about the future in multiple domains while trying to fall asleep, whereas in ADHD it might be impulsivity issues, poor organizing, being kind of glued to devices, and poor sleep hygiene. So there are ways that take a lot of skill, experience, and effort to disentangle if it's anxiety or ADHD. And sometimes it's not clear, and you kind of have to try and work out which one's the more likely one and treat and see what the response to treatment is. Because if you have ADHD without anxiety, you're unlikely to respond to SSRIs, and you'll respond to stimulants usually, and vice versa. If you have anxiety and you give stimulants but you don't have ADHD, it could make the anxiety worse, and that would be helpful in the diagnosis. It would likely kind of reinforce that diagnosis. So anyway, I'm just ranting on about kind of some of the considerations to make between anxiety, ADHD, and depression. But yeah, it's a really common challenge that we have to try and disentangle what's what. And I think it's a video in itself, how to distinguish anxiety from ADHD. And if you guys are interested in that video, I'll do it. But just remember, you can't diagnose yourself off of YouTube. You have to see a psychiatrist. All right, next comment. Let's go. Okay, next comment, Camo222. I do know that there are hypnagogic and hypnopompic hallucinations. With a psychotic disorder like schizophrenia, is it possible to hallucinate while sleeping, not in the sleep to wake or wake to sleep stage? Or would that just be your everyday experiences influencing and flowing into your dream states? Hope that makes sense. Absolutely adore these videos. Thanks, Camo. Great question. For those kind of not aware, so hypnagogic, I remember it as going to sleep and popping up. So hypnagogic, you're going to sleep, is when you experience hallucinations, while you're falling asleep. So some people might, as they fall asleep, hear their names being called, or if they're grieving someone, they might hear the voice of that person that they've lost. If they're in a very anxious state, they might see scary figures as they're kind of falling asleep, and they don't know if they're awake or asleep. Yeah, so that's kind of falling asleep, the hypnagogic, and the hypnopompic in the morning when you're waking up, same thing but on the way out. The question is like, can you hallucinate whilst asleep? And technically, that wouldn't be an abnormal perceptual experience. I mean, a hallucination, what is it? It is it's a false perception, right? So we all are getting sensations that we interpret, and the interpretation of those sensations is our perceptions. So it's a perception without a sensation. So for example, a sensation of sound. So in a normal situation, a sensation of sound enters my ear, goes through my auditory nerve into the auditory cortex, and then I have all these neurons that go into the auditory cortex and associate it with meaning, and that's the perception. But I get the sound to make the interpretation and associate it, and that's the perception, that interpretation part. In psychosis or in an auditory hallucination, there's no sound. The auditory the perception of sound is happening without the sensation, and that's a hallucination, and that can happen in any sense. So although we talk about hearing voices as the most common one, absolutely there are visual hallucinations, tactile hallucinations, olfactory hallucinations, gustatory hallucinations, taste. And did I miss one? So touch, sight, sound, scent and taste are the 5 common ones. But then there are other odd hallucinatory experiences, like the feeling that there's someone just behind you all the time, like you're always turning around, they're just always right behind you. And there's also things called extracampine hallucinations, where you're experiencing a sensation that is beyond the possible realm of your biology. So hearing somebody whispering in a different country, for example. So lots of interesting psychotic phenomena has been observed, but it's not a hallucination if you are asleep in a dream. Okay, that's a dream experience or a nightmare, but it's not a hallucination because it's not a bad question, because if you think about it, the entire dream could be considered a hallucination. If you loosen, like when you're asleep, when you're in a dream, you don't kind of know it's not real, in the same way that psychotic people don't know that it's not real. And there have been scanning of brains when people are psychotic, and they find that similar structures when people are in dreams are activated as when they're in psychosis. And you think about it, when someone is in a dream, they often have a lack of perception of time. They have a lack of knowing how they got to places. They might be having kind of bizarre experiences that feel normal, so like being abducted by aliens or flying or things like that. And those things can also happen in psychosis, where there's time blindedness, and they might think it's they don't always think it's the wrong year. Like usually people are oriented. If people aren't oriented, that's usually like a bit of a worrying sign that it could be something else, but it does happen. But yeah, they can have bizarre beliefs as well, like, you know, like a alien has abducted them or something like that. I use the term bizarre not as a pejorative, judgmental thing. It's the term that we use in psychiatry to describe something that is extremely, extremely unlikely, like aliens abducting people. Although I recognize some people believe that. It's just unlikely. All right, next comment is by Anne Schmidt. We're doing well with time. Hi, Dr. Sill. I have a question for you. After watching your last two Q&A videos, I've noticed you've really emphasized how babies and toddlers look to their caregivers for modeling to decide how to act and help unjumble their nervous system. I suffered from postpartum anxiety, PPA. Luckily, my husband was here to help with our baby as I was also receiving help. However, can a child be permanently damaged, for example, via increased risk of anxiety or attachment disorders by this temporary lack of assistance? I remember my therapist saying to put her in a safe place when I felt too overwhelmed to be a good carer at the moment. So I put her in a safe baby bouncer while she cried, and I cried. After a few minutes, I was okay enough to calm her. It's moments like this that still bother me 6 years later. Thank you, big fan of your videos. And thanks for sharing such a honest and painful reflection. I think you're right. I have been kind of focusing on the role of caregivers in organizing a young person's nervous system. And I tend to probably put too much pressure on caregivers. The first thing to say here, Anne, is that there's so many things to say. Number one, it's about being good enough. Okay? So it's not about always being there for your child. Okay? It is a part of life to be distressed and tolerate imperfect responses to that distress. So being left on a baby bouncer while crying is not, necessarily correlated to irreversible damage at all. Okay? So it's about being good enough as a parent. It sounds like your partner was very helpful and absolutely would have been, helped buffer any of the effects that your anxiety may have had on your toddler. But the third thing is like you're clearly getting your own help, and that is invaluable. That's what a child needs to see, that a parent can get their own help and get better, and that models into them. And if they have issues, then they can get help and get better too. What's harmful is if a parent has an issue and avoids getting any help and things get worse. In terms of anxiety, your anxiety and your toddler's anxiety, look, it's not as simple as you having anxiety means your kid's going to have anxiety. Or if your kid does get anxiety, it's not necessarily because you had anxiety. It's multifactorial, right? There's the kid's genetics that inform their temperament and their response to caregiving and their ways that they attach. There is the exposure to parental anxiety that does have some influence in how they go about the world. It doesn't mean that it's going to be a devastated life. And you got to remember, anxiety has strengths. It's useful to have anxious people in the world, especially like there are ways to use anxiety for it can be a strength. Absolutely. Obviously, if it crosses the threshold into kind of a disorder, we've got to find ways to bring it back into the realm of helpfulness, and that's totally fine. And I'm sorry to hear that these memories are still bothering you, Anne. I hope that you can forgive yourself. And if you haven't, I would consider kind of working with a therapist on this, because you can kind of realize that you probably wouldn't judge any other mother as hard as you're judging yourself. And sometimes you need to redirect that kindness you have to others to the self. And I'm just really grateful for your question and open disclosure. So the other thing is, if you're someone else watching this, just be aware, at least in Australia, that there's a lot of peri-mental health services, and that getting help whilst pregnant, if things aren't going well, earlier the better, right? And protecting sleep is the most important thing. Well, it's one of the most important things. And There's a lot of help out there. So just Google Peri Mental Health Services, talk to your midwives, talk to your GP, and get the support you need, because peripartum anxiety, peripartum depression, peripartum psychosis, mania, it's all treatable, and catastrophes can be prevented. I don't want to get into my experiences of the dark side of things that get untreated, because it's not the right time to talk about that. But just it can be very bad outcomes if people don't get the right treatments. So do look into it if you need it. Next comment. All right, Sherry Jennings, 9309. Hi, Sil. Not sure if you can answer this one, but what can teachers do to help students with dyslexia? I guess it would be specific to the student, but can you give some examples? Also, what is your favorite tea blend? Oh, this was the tea question. And can we please see your dog more? You want to see my dog more? All right. Hi. Hello, my boy. Hello, my boy. So, guys, as a little plug, this haircut, that is me. I am grooming my own dog now, because it costs $130 to get it done professionally, and I thought, I'm going to save $130 and groom him. So you guys tell me if he does look a little bit scruffy, doesn't he? But he's such a cute boy. Oh, he got me in the mouth. He got me. Bit of hot tea to sanitize that. Okay, the tea blend is I think I said you can hop down on your bed. Okay. I talked about some of there's one other tea that I didn't talk about because I forgot its name. I'll just put a photo of it here, and that is the yummiest tea I've had in Australia. So good in the morning. It's like an Indian spice blend, I think, with like cinnamon and all cardamom and all good. Yeah, just yummy. Love it in the morning. Anyway, back to the dyslexia. Let's get back to the mental health side of things, guys. Come on. I think the main thing is supporting their self-esteem, right? It is so easy for someone with dyslexia to really lose confidence in their self and get low self-esteem from poor reading, because it just makes them feel stupid, and they can get bullied for it. So it's about getting whatever, an optometrist, getting you're right, it does depend on the patient, I'm realizing. So just you got to work with their care team, talk to their GP and optometrist, and try and find what's the best way to support them. Sometimes occupational therapists are really helpful. Okay, Albie wants to come up. Come on, my boy. Come on. But I hope everything's going all right with your student. All right, Sarah Hamilton, 1722. I have BPD severely, and I am on the full gambit of psychiatric meds. I also have done DBT many times, trauma therapy, etc. I feel like I am never going to get better, yet it is said that BPD is highly successfully treated. Is it possible I am untreatable? Sarah, thanks for the comment, and this is a really common and painful situation. So BPD, borderline personality disorder, which is a constellation of symptoms that, just for people who aren't you, Sarah, who don't know about it, it's issues in how one relates with others. There's patterns of unstable relationships, dramatic, high expressed emotions, incredible idealization and intense attachment, and sometimes even enmeshment, losing yourself in the other, followed by very quickly devaluation, fights, and thinking that the person is terrible, so very big highs and lows in relationships. Same pattern in how they relate to the self, right? So often lots of highs and lows in how they see themselves. And when there's lows, a lot of suicidal thinking and behaviors, and even sometimes attempts. There can be chronic feelings of emptiness, lots, and then a lot of acting out, and so lots of symptoms that cause problems in how they see themselves and relate to others, and a lot of pain. It's a very painful illness, but it's also very treatable, as you say, Sarah. So It's probably one of the most unstable diagnostic labels. Just because someone has borderline personality disorder in their teenage or even 20s absolutely does not mean that in their 30s and 40s they would meet the criteria. And some studies have said as much as 80% of people after years of therapy, like DBT, do get better. There are the 20% that don't get better, that do have complex lives. Things that lead to treatment resistance are things like substance use, and lack of engagement in therapy, and inability to form a kind of therapeutic alliance with therapists. DBT, trauma therapy, don't forget mentalization-based therapy, schema therapy. There's other evidence-based therapies for BPD, and the therapist is so important as well. So finding the right person for you, Sarah, that you can form an alliance with, even though you might not always see eye to eye, is really important. So I don't think anyone is untreatable, Sarah. I do think a big risk that is seen in people who have BPD is polypharmacy, is too many medications being prescribed. And often what's happening there is that the distress in the patient is being felt as a countertransference in the prescriber. And that's called countertransference prescribing. And then that prescriber might feel the need to prescribe something in order to help the patient and soothe their own anxiety. And like they're prescribing something to soothe their own anxiety of the situation. So, a patient comes like saying, everything's falling apart, I'm going to die, I can't keep going like this. But actually, the long-term pattern is a long-term thing, and and although that pain is very real in the moment, there's a stability to the instability, and you haven't needed medications till now. There's nothing that's really changed, so why start a medication now? And sometimes you do have to. I'm not saying you don't, but you just have to kind of have a strong clinical rationale and have a specific thing you're trying to treat as a prescriber. You need specific thing that you're trying to just treat. So when someone says, I just want everything to just not be so bad, that is not specific. I need a particular goal. What is this going to try and fix? And we need to measure it. And in 3 months or 6 months, what do we do if there's no response? Do we stop it, increase the dose? You need to come up with those plans early and be specific to avoid what I have seen, and everyone has seen, is people with BPD in their 40s and 50s on 8 or 10 or 12 different medications. Look, I'm simplifying. Often there's complexity to those situations, but you just want to, less is more. Less is more when it comes to personality dysfunction. Okay, so that's a kind of important caveat to make. So I don't think you're untreatable, Sarah. I think you've clearly been dealt a really difficult hand, and it's just about learning how to play it and finding a way. The final thing I'll say is that DBT, not so much trauma therapy, but definitely DBT, it's like going to a gym, okay? You can't, just because you do 1 set or 2 sets of DBT doesn't mean the 3rd or 4th set won't work. It's about strengthening the muscles, and I'm using a metaphor here for, the networks of the brain that build healthy defenses, healthy ways of coping with stress. So it's about building healthy ways of coping with stress, Sarah. And in time, I hope things do get better for you. Definitely, if there are any substance use issues, they make things much worse in BPD. So just for anyone who's suffering with personality struggles or disorders, substance use just makes everything worse. So do avoid it if possible. All right, we're at time there, so I'm going to leave the video there. Thank you so much for tuning in till the end. If you enjoyed this video, all I ask is a like of the video, subscribing to the channel, share it with a friend, and most importantly, please leave a comment down below, because that's how I make these videos. If I don't have any comments, I don't make these videos. If you have anything, any curiosity, something that's come to your mind, chuck it in the comments down below and I'll do my best to get to it. Thanks again, guys. I'll see you in the next video. Bye for now.